So without further ado, I would like to introduce our wonderful speaker, KatarinaLee. Ms. Lee was born in Manitoba and raised just outside of Carman, Manitoba. As a devout Catholic, she became interested in questions surrounding medical care at the age of 12, when her grandmother was hospitalized for 19 months. Those questions led her to study philosophy, law, and bioethics. Ms. Lee is currently the clinical ethicist at St. Boniface Hospital and also an assistant professor at the Department of Family Medicine at the University of Manitoba. She holds a Bachelor of Arts in Philosophy from the University of Dallas, a Master's in Arts in Bioethics from New York University, a Juris Doctorate with concentration in Health, Law, and Bioethics from the University of Minnesota, and a postdoctorate in Clinical Ethics from Bayer College of Medicine and Houston Methodist Hospital. So she comes to us with a wealth of knowledge to share with us here this morning. Please help me in extending a warm welcome to Ms. KatarinaLee.
Can everyone hear me?
Yes.
Okay. So, good morning, everyone. Thank you for coming out. It's quite frigid, I know, and I'm still getting used to Manitoba winters after a decade of not experiencing them like this. So, yeah, my blood is definitely thinned. So, we've got two parts today. I'd encourage you to ask questions. I'll be around afterwards, too, if you want to talk more. I've got business cards, too, if you want to call me later if there's anything else that comes up. But we're going to go through two parts. First is surrogate decision-making and advanced care planning. And then the second is going to be more of just an informational session on medical assistance in dying, kind of where we're at, what's happening in the province of Manitoba. So this presentation is broken down into the following concepts: autonomy and informed consent, talking about what is actually capacity and decision-making capacity. Then we're going to talk about the proxy system, healthcare proxies, and advanced care planning, more of the directives, which we can see online and we talk about quite a bit. But it's just important to have a bit of a structure going into proxies and directives. So, what is autonomy? Autonomy essentially is an individual's ability to make decisions based upon their own values, philosophical, religious, or otherwise. And so when we say we're respecting a person's autonomy, we're respecting decisions that individuals make. So we see this in all sorts of decisions. This is not just medical decisions, but it's just the framework of autonomy is for you as an individual to be able to make decisions that are in alignment with your own preferences. So what does it actually mean for informed consent, though? So how many of you are subscribers to like anything electronic, anything like online? Yeah. Okay. Netflix. Yeah. So you know like those little click to agree buttons when it's telling you to update your software? How many of you have ever read those? One. We got maybe one, two. Okay. Right. So the reality is we don't actually read those documents, right? But that's technically a form of informed consent. You're clicking to agree. But that's not the standard of which we would want to have in the medical context, right? We would like individuals to be able to understand more than just signing a document. So informed consent from a medical and an ethics perspective is that we want the patient to understand risks, benefits, consequences, and alternatives of any given treatment, of any given decision that they're making. So it's a higher standard. It's not the Netflix click. It's actually meant to allow you to engage in a conversation with your physician, your care provider, your family, for you to have questions and have those answered. So it's more robust than the click to agree. Yes. So now we talk about capacity a lot in advanced care planning, healthcare proxies, medical decision making, but it's important that we talk about decision making capacity. So often this concept of globalized capacity, or they're incapacitated, or they don't have competency, gets thrown around quite a bit. And there are obviously circumstances in which people are in a coma or they're sedated and they're not going to be able to engage in any sort of preference regarding their medical decisions. However, the key is to actually talk about decision-making capacity. So when you're thinking about your own advanced care planning and you're talking to potentially your family or your proxies, I really want you to think about decision-making capacity. So that means in this given decision, do you as a person or a patient have the ability to understand the risks, benefits, consequences, and alternatives of this given decision? Not all decisions, but a specific decision. So we see this a lot with patients and people who have dementia. So in the morning, they may be really good to engage and have conversations and make decisions, but it's the sundowner effect. So by the time they get to the afternoon or the evening, they may not be in the best place to be able to engage in decision making. But that doesn't mean that we say you never get to engage in decision making. It's just respecting that there are moments in which people do have decision making capacity, and then there are moments in which people do not have decision making capacity. I also would encourage you to use the term capacity when we're talking about medical decisions and advanced care planning. Competency starts throwing in some other legal terminology, which is when we're talking about advanced care planning and proxies, it's just important to think about capacity in medical decisions. So who actually makes these capacity assessments? So physicians make them, psychiatrists, ethicists do not make them. And baseline, the presumption, the legal presumption, when in doubt, a person has decision-making capacity. So if you present to a hospital or you present to any sort of facility and a physician may be kind of worried or it's on the line of whether the person understands, the presumption is that they do understand. Interestingly, in Manitoba, the age of capacity in regards to medical decision-making is 16. Okay? So
16?
It's 16, yes. So it's not 18, but it's 16. So that's just important to keep in mind because we're going to talk about that again when we get to healthcare proxies. So what are circumstances that actually affect yourself, myself, any patient's potential ability to engage in decisions? So it's situational, it can be physiological, but it can also be psychosocial, neurological. There are a lot of different aspects that can impact a person's ability to make decisions. I see this too in more of an acute setting where people get what we call ICU delirium. So they've been in such an acute critical situation for so long that they start not really understanding their surroundings. And it's just because you're in the same room, in the same environment constantly, and you're not having your normal routine. So it's also important to note that, just like the click to agree, not all capacity assessments are the same. So when we're talking about the ability for someone to make a will, that's a different assessment that has to be made versus a medical assessment. So when you go get a will made, you sit down with a lawyer, and that lawyer determines whether or not you understand your assets, where they're going, that you're making a will, and the standard in which you make a will is different than the standard in which you're engaging in your medical decisions. The idea is that it doesn't eliminate people from engaging in types of decision making. So that when you're in the medical context, it's really, do you understand risks, benefits, consequences, and alternatives? That's what we think about when we think about making medical decisions. So what is surrogate decision making? Surrogate decision making falls into basically 3 different categories in Manitoba. So there's a healthcare proxy, there's the comedyship process, which I'm going to touch on lightly. It's not as relevant in this circumstance. And then there's family and friends. So this is somewhat governed by something called the Healthcare Directives Act of Manitoba. It's just important that there are kind of the 3 areas in which we're engaging in surrogate decision making. So what actually is surrogate decision making? It's also called substitute decision making. So actually, what is it? There's really 2 standards when we think about it. It's a third party making decisions upon your behalf in the event that you do not have decision making capacity. So for example, the patient who has dementia, in the morning, they're going to engage in decision making, but by the time we get to the afternoon, a third party may have to be making those decisions for that patient at that moment, depending on whether it could wait, whether they could engage in a conversation the next morning. So the first standard is substitute decision making. So, for example, let's say my proxy is my brother. So, in the case that my brother is my proxy, and I do not have decision-making capacity, my brother has to put on his Katarina hat and think, what would she want to do in this circumstance? That's the first standard that we think about. Substituted decision making. It's not what he thinks is great for me or best for me. He's actually thinking what I would want. Now, in the event that he doesn't know what I would want, it then moves to a best interest standard. So what is in the best interest of Katarina at this point in time? And that often engages in a lot of conversations with medical staff, other family members, friends, to see what would be determined in best interest. But those are the standards that we need to think about when either you're acting as a surrogate decision maker, or if you're the surrogate decision maker, you're appointing one. So those are the standards. So what is a healthcare proxy? So how many of you actually have a healthcare proxy? Okay, this is a better group. Because sometimes I only see like 2 hands, and that makes me worry. So healthcare proxies are basically the only mechanism in Manitoba for you to be able to designate a legal decision maker for medical situations. Okay? And so a healthcare proxy is legally binding. It's an individual that you put on either a proxy form or an advanced care directive form that's got a portion for proxies, and you yourself are appointing your preference for a decision maker on your behalf. It's often a family or friend. It's often your spouse, but it doesn't have to be. You can choose and designate whoever you would like in that circumstance. It's also important, of the people who have healthcare proxies here, how many have actually told their proxy that you appointed them? Okay, there's a few less hands this time around. So part of the problem is we actually make these documents and then we never tell the person that we've designated that they're our proxy. Well, one, what happens if that person is maybe uncomfortable being your proxy? But 2, if they're not notified, how are they going to know when you're in the hospital or when you need assistance that they're the person that the hospital should be calling, that you should be engaging in decisions with? So first off, please make one. And then secondly, make sure you actually have a conversation and you're choosing someone who understands your values, your beliefs, your preferences, and what types of decisions, more global decisions, you would want made in given circumstances. So a healthcare proxy is often made with an advanced care directive form, but it doesn't have to be. So in my case, I have a healthcare proxy, but I don't have an advanced care directive form. And we're going to talk about some of the benefits, disadvantages to having both, having one over the other. Any questions so far? Yes?
Can you name one in the will? In your will?
So best practice is that it's separated from your will. Yeah. And so part of the problem with putting it in wills is that you don't know where it is, who's having access to the will. Maybe it's only at your lawyer's office where it goes. Nowadays, people are moving to, when you get a will made, you might do a power of attorney for all of your financial matters, and then you might do a healthcare proxy as well. So it's all three different forms. Good question. So how do you actually make one? So you can often do it with a lawyer. You don't have to do it with a lawyer, though. And sometimes, it's fairly rare, but sometimes they see it where it's actually a portion of a power of attorney document. So someone has made a power of attorney to deal with financial aspects, assets, etc. And sometimes they put in a small provision that says medical decision maker as well. That is not what I would recommend. I would recommend a separate document because, first off, where do these documents live? And we're going to talk about that in a moment. But secondly, that actually means that a healthcare professional would then have to read this other power of attorney document and siphon through it, and that doesn't always happen. So it's an option, and I have seen it. I've seen it less here than other places, but just to note that that does occur. And the last is there's a really simple Government of Manitoba form where essentially you just put in Healthcare Proxy 1, you put in Healthcare Proxy 2 if you would like an alternate, and then you just sign it. That's all. You sign and date it. If you cannot sign and date it, another person can sign and date on your behalf as long as there's a witness. But you don't need to take this Government of Manitoba form to a lawyer's office. You don't need to get it notarized. You don't have to do anything else with it. All you have to do is sign and date. So, yes?
Where would one get?
So this is, and I have an email kind of list, and I can send you, it's quite a large package, but the Government of Manitoba form, you just type in Government of Manitoba Healthcare Proxy form, it shows up. That one's only a page, really. There's a page and then there's a page of instructions. But there's kind of another guide of some questions that I can send as well, which is a much larger PDF. So, okay, so that's how you make it.
So
yes.
What do you do with it then?
Yes. You are advanced in this talk. So, okay, so we're going to talk about where to get it, but what happens if you want to change it first, okay? So an old one can be revoked by a new one. So if you've changed your mind who you want, or, for example, if your healthcare proxy is not able anymore to make decisions on your behalf, so you can actually make a separate writing to revoke the old one, and this is all under the Healthcare Directives Act of Manitoba. Or you can try to physically destroy the old one, too. My advice is if you're making a new one, make a new one, and just have it signed and dated as a different time, because to try to find all the copies that you have of the old ones and destroying them becomes a little bit more complicated and just a little less practical. So now, but where do you store it? And this is a good question. So part of the problem is in Manitoba right now, we don't have like a centralized database for medical, basically, records generally. So there are all these different things called electronic medical records, there's e-health records, then there's just your paper records, your GP. So my advice to you is keep a copy in your home. Give a copy to your healthcare proxy. So the person that you've actually appointed also has a copy of it so that they can also bring one if needed. Give a copy to your lawyer if you have one. Also give a copy to your GP so that there's one actually in your record. And then the last is also, if you can, bring a copy in the need that you would actually come to the hospital. Now I realize if you're coming to the hospital, you're probably not thinking, oh, I need to gather all my documents before I get to the hospital. So it's not maybe the most practical. However, there are kind of different mechanisms now where, especially in older populations, they'll create a packet that they stick on their fridge that includes like their medications, etc. Slip one in there because that is a package that actually does come to the hospital with EMS. So it's not a perfect system. We're actually looking at trying to get it into just an overall e-health system. So if you would give it to your GP, no matter where you showed up, so say it's Boundary Trails, you go to a clinic in Carmen, you come to St. B, that we actually see that you've created one. Okay, so what are the benefits of having a healthcare proxy? Well, the first thing is that there's actually a human being that you can engage with, that the medical professionals can engage with, and you yourself can engage with prior on how to make decisions. Okay? So there's actually a person that can think about given situations and applying your beliefs. Additionally, they're more likely to know about your change in preferences than a piece of paper may dictate. So if you've had any sort of preferential change, if you've had a chronic illness, and so therefore you may not want to engage in aggressive treatment anymore, they may know that as well. So it's a better avenue. Now, the disadvantages are your personal situations may change, and you may not have updated your proxy. So in Manitoba, if you put your spouse down as your healthcare proxy, and then you divorce, it's completely void. Okay? So you have to do a new one. But, for example, if you're estranged from your spouse, it's still valid. So if there's, and it doesn't, we're not necessarily saying that people are splitting from their spouses, but it's just to note that sometimes these circumstances do change, and the person that you had wanted may not be the person that you would like later on in life. So it is important that this is actually updated throughout time. You're also trusting another person to make decisions on your behalf. So you have to really believe that that person understands your preferences and is really equipped to make decisions for you. And then there's still this question of where is the document, right? So as many times as we try to put them in good places, it's still, there's the opportunity that we may not actually know that someone has a healthcare proxy or know where that documentation is. So,
about the document.
Yes.
You don't make a distinction between an original and a copy.
Right. So An original and a copy doesn't actually matter for the purposes of the appointing process. That's why it's a sign-in date. It's different than like a notarized version or a will, etc. And the idea is accessibility in Manitoba, that a person can just write it out no matter what their circumstances are. So the date's actually the key part on the document. Okay, so comedyship. Comedyship is a fairly complicated legal process, which is not as relevant in this circumstance, but I just wanted to note it. So it is a court-determined medical decision maker, proxy, based upon basically two acts, the Mental Health Act of Manitoba and the Substitute Decision Maker for Personal Care under the Vulnerable Persons Living with Mental Disabilities Act. And so essentially the court determines either a public trustee to make decisions, or they'll appoint a family member or a friend to make decisions on a person's behalf. This is really more in the mental health considerations, and this is not a process in which you as a person are then designating something. We've had to go through this process because we need a decision maker for an individual. So the other policy, and I realize that some of you are not from Winnipeg, but this is a very similar aspect, kind of just provincially wide. There is a Winnipeg Regional Healthcare policy on informed consent, which basically talks about what happens when you don't have a healthcare proxy and you do not fall under the comedyship process. So everybody else in the room right now who didn't raise their hand, okay? So you fall under this category. So in the event that you need a surrogate decision maker, we then look to this policy. And this policy, in my opinion, is not the best policy, and we are reviewing it. But right now, it is a non-legally binding person. So they put in a group of people that is kind of a reference point to make decisions for you, but they're not legally binding. Additionally, some of the language here is quite antiquated. It states in the policy that adult relatives of whole blood are preferential to other relatives, which it's not 1950 anymore, so we need to update the language. Additionally, the elder or eldest of the groups that we're going to talk about in a moment are also preferred too, which then gets quite complicated, and it's like writing out a little chart. So your spouse or common law partner is kind of preferred number one. And then it's children, parents, siblings, grandparents, grandchildren, aunts, uncles, nephew, nieces, and friends. So it's almost like everybody you know can engage in decision-making on your behalf. So it's not the best circumstance, which is why I would recommend everyone make a healthcare proxy. And the reality is, in practice, we go to the spouse or the adult children who are at the bedside, who are taking you to your appointments, who are present. But there is no actual requirement that grandchild say is less important than maybe your spouse's say on your preference. Importantly, as you can probably imagine, all these people are not necessarily going to agree, and they're not necessarily going to know what your preferences are.
Healthcare by committee.
Right, exactly. And so this gets quite messy, and this is often actually where a lot of clinical ethics consults come in, because it's trying to figure out what actually was the patient's preference given all of these different individuals and their views. Yes?
What about when there's a language barrier, as in a person that's
For
just integrating?
For sure. So the language barrier, the best practice is that an interpreter is involved and a non-familial, non-friend interpreter. So a actual interpreter from either the healthcare setting, a nurse, someone else who has language skills, because we're always concerned about how are things being interpreted, and also is there any potential bias that's coming back through too. So there's supposed to be a neutral party. Doesn't always happen because in emergent circumstances, depending on the language, depending on availability, but best practice is a non kind of involved party to then interpret. But good question, for sure. So it's problematic because it's not legally binding as well. And so there are circumstances where, in theory, physicians could try to override decisions and then they can go through a court process. And there's other aspects to that. It generally never happens. But legally binding is, it gives you more security, and so that's why a proxy is a recommended avenue. We do look to spouses and common law partners first, and as I said, that there are disagreements. So this is the Government of Manitoba form, and it states proxy 1, proxy 2, and then you sign it. And then there's this other aspect of treatment instructions for like advanced care planning. We're going to talk about that in a moment because that little box is not really sufficient if you're wanting to put any sort of preference in. Yeah. Advanced medical directives. So how many of you actually have an advanced medical directive? Okay. So there are really good things about them, and then there are some problematic things about them. So when we talk about advanced medical directives, advanced care planning, generally speaking, there are, in my opinion, there are 4 big categories. There are a couple other ones, like organ donation, which can also get brought up. But the 4 big categories are dialysis, code status, and intubation, resuscitation, hydration and nutrition, and the last is actually aggressive antibiotics. So these are kind of the 4 categories that a lot of decision-making falls under. Not all decision-making, but a lot of decision-making falls under. So now, from a Catholic perspective, we're focused on kind of ordinary or proportionate versus extraordinary means to make decisions within those frameworks. So there is a long history of Catholic medical care, Catholicism generally, supporting palliative care measures. So the idea isn't that you have to engage in every single measure possible to prolong your life, but that there are general categories in which we sustain life. And one of them is hydration and nutrition. But we'll talk about in a moment that there are actually limits on hydration and nutrition as well, depending on the circumstance. So these are just like global categories to think about. But when we talk about ordinary or proportionate means, and that gets thrown out quite a bit, and these are definitions that are pretty succinct from the National Catholic Bioethics Center. But ordinary and proportionate means are essentially, with a medical decision, with medical judgment, there is a reasonable hope of an actual benefit to you as a person, and it doesn't entail excessive burden. Okay? So it's this burden-benefit calculus. Now, it's easier to think about these concepts in extremes than it is in kind of the more nuanced. So in the extreme sense, if you have really terminal cancer, and you don't want to engage in aggressive chemotherapy treatments, and you want to move to palliative options, and you want to move to comfort care, you are not obligated to engage in aggressive medical treatments by Catholic moral teaching. Okay? It's your choice. If you would like to, absolutely, but you are not obligated to. And so it's this idea of trying to do proportionality. So we're going to talk about extraordinary means. So it means that from a medical judgment standpoint, whatever decision doesn't actually offer a reasonable hope of a real benefit, and it entails significant burden. So in the case of the terminal cancer, if you are undergoing chemotherapy treatment and maybe it gives you 2 more months to live, but it makes the entire time very unbearable, very uncomfortable, just for those extra 2 months, you aren't required to engage in really aggressive treatment. Now, it's important to also think about this in kind of the nutrition, hydration context as well. And this is where it gets a little bit less clear, I would say. Cancer is a little bit easier to think about, either treat or move to palliative. When we talk about nutrition and hydration from like a Catholic moral stance, we're really focused on just maintaining the level of dignity that a person had prior to needing assistance with hydration and nutrition. But there are circumstances where feeding actually becomes quite burdensome to the patient. So I had a patient who, based upon their faith tradition, which was not a Catholic tradition, that they needed to continue to feed until like the very moment of death. And this got to the point in which there was a feeding tube and the person's stomach was distended, they were in fluid overload, it was clearly very uncomfortable, causing a lot of discomfort and pain, but their belief stated that they needed to continue to feed until the moment of death. From a Catholic moral teaching, if you're in that circumstance, that arguably falls into not kind of the normal hydration and nutrition. Now, I get asked this question a lot in dementia care. So people who are no longer wanting to eat, and they're no longer wanting to engage in eating. And that's why this is kind of a global thing to talk about with your healthcare proxy as well. But when you're no longer wanting to eat, at what point do you override that? And at what point do you risk other things like aspiration, choking, tubes? And so the hydration and nutrition, probably 20 years ago, I think there may have been a more, like, we absolutely feed. And this isn't to say that we don't feed, but there are certain circumstances, particularly at the end of life, where people are maybe not wanting to eat anymore, and it's becoming more uncomfortable for them to eat than to provide things like pleasure eating, which is where people will eat whatever they want near the end of life, even if there's a concern about choking hazard, but you start doing this kind of weigh between benefits and consequences. So it's not super clear, and that's why I prefer the proxy avenue as the first avenue for advanced care planning, because then you've had these conversations with a person. So the benefits of advanced medical directive generally, and putting it in writing, it means that it gives surrogate decision makers guidance. So it's good to have global, right? Not in this given circumstance in which I have been intubated for the last 2 weeks and I've got terminal cancer and I'm experiencing organ failure, you are to do X. It's meant to be more of a global circumstance of, for example, if I'm on a ventilator for more than 2 months or 2 weeks, giving the timelines is more complicated. It's more of a guideline of, I don't think I would want to live long-term on ventilated support. Or I might want to live long-term on ventilated support. But giving these kind of frameworks of like, I hit 2 weeks, I hit 2 months, doesn't necessarily work. And so it's meant to be more global when you're writing out your preferences. It also gives medical practitioners guidance as well, except for when they're poorly executed. So I had one once where someone wrote on just a piece of paper, just, straight line paper, I don't want to live in a vegetable state. That gives me no guidance. Like, no guidance. What does that actually mean? In what circumstances? I think they meant persistent vegetative state, but that's also changed too in the sense of like cognition, how much brain function. Does that mean I wouldn't want to be in a coma for more than like a month? It gives me no guidance. And so it's good to give kind of general guidelines of things like dialysis, aggressive antibiotics at the end of life, hydration, nutrition, whether or not you would actually want to engage in CPR. And those things are good kind of global conversations, but having them very specific or having them too vague then causes other problems for the person who's trying to understand your preference. And so the other aspect too is people don't update these documents enough. So when you're 25 making an advanced care directive, your views may be very different when you're 65. And so you need to go back and look at these documents, and kind of general recommendations for updating documents is if you've had a significant life event. So your spouse may or may not be there, you may be getting married, you may have had a child, the person you wanted to make decisions for you is maybe not available anymore, you've had a chronic illness or a diagnosis, something else has changed. Those are always like good factors to think about. I should go back and maybe look at my documents. The other thing is to do it. So we think about doing things a lot, and then we are like, well, but that can wait. And then 6 months, a year later, when you're actually in the hospital and it would have been useful to have something updated, it's just important that when you actually think that it's time, that you make a point of changing it. It also cannot account for every given situation. And so from a Catholic moral teaching, our goal is to preserve the dignity of a human being, but at the same time, it's not meant to just prolong absolutely everything. And so a lot of this is about palliative options too, comfort care options. And it's important to note that palliative is not just the last 3 days of your life. There are people who have cancer who, for example, are on palliative chemotherapy. So they're on palliative because it can reduce their tumor sizes, it can make them more comfortable, and that can be months long, that can be years long, you can be palliative. So it's just important to think about how this is also related to longer term kind of goals in life, and how you want to live your life when you may have a chronic illness, when there's an acute event. And so my advice generally is that you make a healthcare proxy, you make a directive if you feel as though you would like some guidance, but not to make it so specific that the person who's making decisions for you is not like able to use their discretion and their judgment in any given circumstance. Okay, I think we're going to go for a break, but if you guys have more questions, I'll be up here.